Good evening, ladies and gentlemen. Welcome to Reference Point. I'm Dave Coker-Hook, and we're back for the second set of discussion here regarding the Affordable Care Act. With me again, Kathy Brown, Michael Lujan, and Dr. Shane Dormady. So, folks, thanks again for sticking around for this second discussion. And I want to go back to something we started to talk about at the end of the last episode, which has to do with the levels of offering, the bronze, silver, gold, platinum levels. We mentioned that, and we mentioned that people, when they go into the exchange, have some possibilities of what they can select. And I believe, Kathy, during the break, you said that the offerings from the service providers, if you're not getting it through the exchange, have similar types of structure.
They have the exact same.
They have the exact
plans.
same. Okay. But you also said something about making sure you understood what it means to be at the different levels. So could you kind of touch on that?
Okay. As far as the actuarial value of the bronze, silver, gold, and platinum, if the bronze is at 60%. So as Michael said, the benefits in that, the actuaries determine that it's at 60%, which means that the premium is going to be lower for this plan, but it also means that when you go for services, you're going to pay more out of pocket for that.
Let me state that in terms of dollars and cents. So if it's a 60% structure, that means if it's a $10,000 procedure, that the insurance company will cover $6,000 and I get to pay $4,000. I have the privilege of paying $4,000. Okay.
Right. Up to a certain amount, whatever your out-of-pocket limit. Whereas on the platinum plan, well, let's back up. On that bronze plan, you may pay $200 for the premium. But on the platinum plan, it'll pay 90% of that $10,000 procedure. But the premium could be double, $400 per month on that. So you would pay more.
The other thing you just mentioned here that I hadn't thought about was there is a maximum dollar amount that, as a consumer, that a ceiling that I have to pay up to, but if the costs are higher than that, does the insurance cover that?
Correct. So you would have a deductible of a certain amount that you would choose, and then after the deductible, you would pay a percentage of whatever the negotiated rates are on the expenses, up to a certain level. And once the bills reach that, so if you have that $100,000 procedure and you're hospitalized, or $1 million procedure, that's why one of the laws on ACA was it's unlimited benefit. So, but once you reach this calendar year maximum, the insurance company pays 100% after that.
Got it. Thank you. Appreciate getting that clarification. So one of the other things that we talked about a little bit was this, between shows here, was the impact on what happens if there's a situation for a patient where you've done your assessment and it looks like this is what's going on, and you prescribe a treatment protocol for that, but as you get into it, you find out, oh my gosh, there's more going on here than we had anticipated. And what does that mean for the patient? And Dr. Dormady, you were making some additional, I think we sort of touched on this earlier in the other episode, but I kind of want to get back on this one because I think this is significant in some way, and I want to understand what it means for us within ACA.
Well, absolutely. I'm glad we're going back to ask a couple questions about the impact on patient care. And one of the things that I, as a practitioner, noticed right away, and Michael and I and Kathy, we were laughing earlier that doctors are notoriously bad businessmen and completely politically unaware, even with things that affect them directly. So I think the patients and doctors are in an eerily similar position as, nobody knows what's really going to happen until these things start happening. And one of the first things I noticed is that, or one of the first things that was implemented was something called a sequester, where certain funds were sort of sequestered and withheld by the government, such that as an oncologist, many of the newer and more expensive drugs that we were administering in the office were now underwater, such that
meaning
that it was costing us more to administer the drug in the office than what we were getting paid for it. So we were losing money with each infusion.
Wow.
So this has been pervasive across the country, where unfortunately, doctors are having to go to their patients, and the patients are extremely upset, and they're saying, we have to move you out of this office setting away from the nurses and we have to go into the hospital to do the infusions, which ironically has an astronomically higher cost than doing them in an outpatient setting. So I think, and that's something that I can tell you has impacted our practice directly. All of the physician partners have looked at each other and been stunned at how much the infusion revenue has dropped and by how much money we've lost on drugs and how that's impacted patients. Patients are horribly upset to have their venue changed.
But what you've said there is not only does that impact you as an individual practitioner, but the cost of the care service for the patient goes up when they go to the hospital.
It does, and I think the overall financial burden to the system, it's also going to drain much more money. And I think there are many of my partners, politically active, writing letters, talking to representatives, and everyone knows that's a problem. But the fix, the remedy, is not it's not coming quickly.
Wow.
So that's an issue. And I think another impact of, we talked earlier about bundled payments and impact to the patient. I think while it's good to do self-examination about the more expensive therapies, I think in many situations the more expensive therapies are warranted. And my fear is that a lot of patients may be driven away from some of the newer therapies that are expensive, frankly, but may help them the most. And
because of what reason?
Just on a pure cost level. If, as we spoke of earlier, if a certain amount of funds or money is available per patient per stage of cancer to treat the disease, then I think it's only going to be human nature that the practitioners will think about, how do we stretch the dollar longer? Maybe we should stay away from some of the newer medicines.
What you just said there, and this is something I hadn't been thinking about, but what you just said there implies to me that there is some type of, some decisions have been made somewhere by someone that says this would be the logical amount of money that we would expect a patient in this circumstance to receive to cover whatever their treatment would be. Is that what you're saying?
That's correct. I think actually some payers are even talking to our group about setting just certain paradigms of care for stage of disease where you have a set agreed upon first-line therapy that you will use and implement in your practice, and then a set second-line therapy, and possibly a set third-line therapy. But at that point, what's called palliative care would be recommended, or more of a comfort care philosophy, and not further aggressive therapy.
Right.
So that's, again, I think that while there's logic to that, and I think that will certainly limit costs, I really worry that for individual patients, that their prognosis could be compromised in that sort of system.
One of the things that I've heard that I don't know if it's actually part of ACA or intended to be or hoped to be, but has to do with more of the electronic management of information and etc. Is that so? How does that impact things?
Well, that's another hot topic, and I think it's very interesting. There are these ideas that you think in your head will be so beneficial. You have an electronic medical record, information can be shared. I'm just clicking a button and sending information to a patient's primary care physician, sending prescriptions to the pharmacy, and so forth. And it is wonderful when it works. I think there are a lot of bugs in the system that need to be worked out. Obviously with any sort of computer system like that. But what's interesting, again, when you think of the patient and the individual, and I know this from our practice and others, it's a universal patient dissatisfier, as all the doctor's doing when the patient comes in is this. Typing on the computer, there's virtually no eye contact. You're listening with one ear and typing in the computer with the other. So while the medical documentation and those sorts of things for billing purposes, what have you, is great, you really start to lose the classic feel of the doctor-patient relationship and the trust, especially oncology, that has to be there as you lay your life into a doctor's hands. So it's really, we're walking that tightrope again between compassionate care and
these systems that are looking to be put in place for this kind of a thing. Do they, and you may know this, Michael, I don't know, but do they also provide indicators. I'm a software guy. I spent many years in the software industry, over 20 years in the application software industry. And I know, and we did stuff in manufacturing systems, right? Guys who were building things. And you'd put things in there like if the guy wanted to try to put part A in with part C and it wasn't going to work, he'd get a flag. It ain't going to work. Okay, you got to pick a different part because this part is incompatible with what you're trying to do. I envision, as a software guy, I envision the intent to have something similar in the treatment protocol software stuff, which makes me worried about who it is that's designing the software, because when I was in the manufacturing software business, the guys that were writing the code had never stepped into a factory. And so I wonder how much these people actually know about what it is they're trying to create.
If I can just sort of clarify, or maybe just editorialize, I think what Dr. Shane is describing is market-wide. There's a broad effort to try to help bend the cost trend, the healthcare cost trend.
Sure.
So I just want to make sure that what he's describing, I think, applies universally. It's not a product of the ACA, it's not a product of exchanges. This is sort of industry market-wide where there's this tension to try to make some reform on the delivery system. You have integrated healthcare models, accountable care organizations, ACOs. Those are becoming very popular, where you have hospitals, physician groups, and health plans coordinating information, trying to drive the waste out of healthcare.
Sure, makes a lot of sense.
And they make a lot of sense, but I think what you're hearing is some of the detail that especially when you get into his level of care, where it can be very concerning, where you're talking about bundling procedures and that sort of thing to achieve a lower reimbursement rate. We're talking literally life and death impact. So, but it's market-wide. It's not a product so much of the ACA.
Right. Well, I'm going to suggest that these issues that we're finding appear as part of this implementation of a new strategy. You can't think of everything when you start out on a campaign. And so one can hope that as these issues become visible, that there are intelligent people who are going to look at it and say, okay, let's make some adjustments here. Let's fix this. This is a problem. Let's fix it. And because I'm not looking, it's going to happen. This process is going to occur. So let's figure out how to make the greatest positive utilization of it. Which takes me into the question that I mentioned at the end of the last show that I wanted to talk about, and that is what happens for the small business owner, because small businesses, that's the lifeblood of the economy, really. I mean, they say that of the 30, I don't know how it is, 30 million, 32 million businesses in the United States, like 30 million of them are under 100 people in the company. So the majority of business activity or with small companies. They're not the big employers, but guess what? If you get each one of those guys to hire one guy, you're putting 30 million people to work.
Right.
But there is an impact as to, do they have to now, because of ACA, does an employer have to offer coverage to their employees?
They don't.
No, they do not.
No, they don't.
They do not.
Let's just get that right out on the table. No, they
but
do not.
In my work with Covered California, when I was making the rounds, they have a program called SHOP, the Small Business Health Options Program. And part of that work of introducing SHOP through the exchanges to get out to small business and tell them what's coming, that was the number one myth, that most of them thought they were subject to a penalty or a mandate. So small employers, many of them provide coverage today, and many of them will in 2014, none with a mandate. No mandate now, no mandate in the future. But there's a lot of confusion. There's a lot of uncertainty. I was reading a study just yesterday where I think it's 45% of people surveyed think that this has all gone away already, that it's been repealed,
wow.
that it's been delayed, that, yeah.
Wow.
So, I mean, and this is, as you put it, 20-some days away from launch.
Right.
So there's a lot of work to do to get information out, a lot of misinformation and disinformation.
Well, let's clarify some things for the business people.
One of the things that all businesses, no matter what size they are, by law, they are supposed to notify all of their employees about the exchange and subsidies. So we sent out a sample notice that all of our employers could use, but they do need to make sure that they send that. Even if they have one employee, they have to notify them.
So they let them know, look, this is coming down the pike, you
Right.
have some options.
Right.
But that doesn't mean that the employer needs to offer something.
Correct.
He or she could, but doesn't have to. Now, we mentioned earlier that with the individual's structure, that if they are at a certain income level, that there is a way for them to get some sort of government assistance to pay for the insurance. It comes in the form of a tax credit or something. Mm-hmm. But if you're paying $200 a month and you can't afford $200 a month, maybe you'll get X amount. Is there anything like that for the small business owner?
There are tax credits for the business owner, yes.
And
But it has to be a business that has under 25 employees, and the average salary has to be under $50,000. Basically.
Okay.
Yeah.
And let's go into this thing about number of employees. I think there's a confusion about this. I've heard this talked about in two ways. One is the number of people that you have, number of employees, and then I've heard people from the Health and Human Services Organization department talk about full-time equivalents. Okay. So I'm trying to understand exactly what that means.
A full-time employee is an employee that works 30 or more hours per week.
Okay.
And the reason they say the equivalent is because if you have a part-time or you have a lot of part-time people, they will add them together, depending on how many hours they work, together to make one, like two part-time people can be made into one full-time. So that would count toward the
25 or 50 or whatever
Right.
the limit is. Okay. Did they not? Did I also understand from what constitutes part-time? Did that change? I mean, what is a part-time employee? Typically in California, going back, 6 months ago, before ACA, what's a part-time employee? Anybody who's working less than 40 hours?
Under 30 hours.
Yeah.
It's always been under 30?
Mm-hmm. Well, for the insurance purposes, it's always been 30 hours a week.
For insurance purposes.
Would be 30 hours a week.
So the employee benefit plan for any company, putting ACA aside, has always been if that individual is less than 30 hours, he doesn't qualify as a full-time employee and he's not going into the program?
Well, some insurance companies do allow part-time people to enroll in the health benefit plan. But if you're a full-time employee, it's 30 or more hours, and that's what the insurance company considers they would be eligible if they offer benefits.
We have new state laws. It's Assembly Bill 1083, and I realize that's getting really wonky, but in case you want to know, there's a state law that sort of absorbs the Federal Affordable Care Act and conforms to California law. And it takes some of the law that we already had in state and puts those two things together. So what we have now are definitions that say California will consider a small business eligible with 1 to 50 eligible employees. What do you consider eligible? Most employers will adopt full-time as 30 plus hours. That's the now new definition. So if you wanted to extend coverage to part-time workers, you could, and that would be your employees 29. Yeah, at your discretion. So typically a full-time employer group, if it's 1 to 50 eligible employees, would be typically 30 hours or more.
Mm-hmm. Okay.
Yeah.
Got
it's
it.
really easy.
It's actually not that complicated, but there's a lot of confusion out there.
And I'll say this without any, not pandering to our guest here on the panel, but I do caution employers to not go through this change alone. The small business rules between the tax credits, the options in the exchange, out of the exchange, individual versus group, how to get the maximum benefit for your choice really is best served with a licensed agent. So, and I say that simply because I think there's also the misperception that consumers can save money by going directly to a carrier or directly to the exchange and bypassing an agent. There's no money to be saved.
It's exactly the
exactly
same
the
rates,
same.
no matter you buy it online,
Yeah.
direct from the insurance company, through one of the exchanges, or through an agent. It's
Which
exactly
is actually
the
a
same
good
price.
thing.
Yeah.
It's a good thing.
Just as you would, and I'm now pandering to accountants, just as I would go to a CPA for that professional advice, same thing with a licensed agent.
Right.
Yeah.
I want to dig into something a little bit more of that in just a second, but I want to remind our viewing audience that they can send questions for any of you regarding what we're talking about to info@referencepointtv.com. So send in your questions, we'll get them to the right people, and we'll get those things answered for you. So, all right, so it doesn't matter where you go to acquire the insurance, it's all the same. But I had heard somewhere, or I was, and I think, Kathy, you and I were at a meeting last week, I think it was, that Congressman Mike Honda had put together, and there was a representative there from
Covered California.
well, from Cover California, but from several of the at least one of the community-based organizations, and there's a lot of conversation at that meeting about how they have these. I can't remember the term they use, but there's representatives, people that.
Navigators.
Sisters, navigators.
Yeah, somebody that you can call into and talk to about this sort of stuff. Let's talk a little bit about. This is not. There's some complexity associated with what it is that we're talking about here. So these people that are there to guide you through the process, what have they gone through in order to reach that point of understanding so that they can be good guides?
I suppose I'll take that one. So, considering the 5.3 million Californians that are targeted to be eligible for Covered California, so if consider the 6.5 million, maybe 7 million uninsured, many of them are undocumented, so excluding that number, 5.3 million is the target. 58 counties, many languages, a huge geography to cover. The Affordable Care Act allows the states to say we'll use agents, navigators, assisters, some of them or all of them. California is using all of them. So we have in California a plan to get trained and certified up to 15,000 agents, licensed insurance agents.
Kathy is a
Just
licensed
like this
insurance
one.
agent. Yeah. Okay.
And another number, and I don't want to misquote the number, but it's about 3,000, I think, assisters. It could be more, maybe it's 6,000, but somewhere in that range. Assisters would come out of community-based organizations. These are folks who maybe serve a specific community or a specific culture or language that might not be broadly reached by insurance agents.
Sure.
So if you think of a specific Hmong community, there may not be a lot of agents who speak Hmong, but there might be a community-based organization who does. And likewise, any and all cultures and languages throughout the state, that's the intent, is to have assisters deployed to reach those folks. Their focus, though, is going to be specifically on the subsidy-eligible market in the individual exchange. In the small business, we were just talking about the small business market, it's exclusively served by licensed agents for the very reason you said. It's very complex.
Right.
There's compliance, there's taxes, and also a very robust market outside the exchange. So licensed agents only in shop, agents and assisters in individual.
Got it. And they're working on trying to get those people spun up to some knowledge.
As we speak.
As
They're
we
doing
speak.
it right now. Yeah.
So I want to ask another question for the doctor over here, because one of the things that I had just been made aware of through some folks that I know in the medical profession. I have a cousin who's a private practice doctor on the East Coast. And some of the things that he had talked about was that he and some of his colleagues had moved more in the direction of offering services for cash rather than going through insurance mechanisms, just because they were able to minimize some of the cost structures for their patients. Does this program, ACA, have an impact in that regard? Would a practitioner still be able to move in that direction, or will you be required to take to have to take insurance coverage?
Oh, I think that's a great question. I think as Michael was alluding to earlier, I mean, some of the things I was talking about before are sort of nationwide, enterprise-wide, but I think, and they're not per se part of the Affordable Care Act, but I think the Affordable Care Act is causing us to take a look at all of our treatment paradigms, look at the overall costs, reduce it, and I think that is impacting, that at least so far, is threatening and is impacting reimbursement to doctors. I think that a lot of doctors are afraid, and I think that many of them are going to shift towards being getting new jobs or participating exclusively in managed care organizations, being absorbed by universities or academic centers. For example, in our area, Sutter and PAMF are very powerful, and a lot of doctors will feel protected in bigger organizations like that, Kaiser. And then an alternate population of doctors may shift to a boutique type practice where you tell patients, I'm going to be basically at your beck and call. Here's my personal cell phone number. Here's my email. Call me anytime, day or night. You'll pay sort of a retainer or premium to me directly for that type of personalized service. And then when it comes to insurance, you pay me directly for what I do, and any insurance vagaries that you have to navigate through are your responsibility.
That's on your. Maybe you can get reimbursed for that, but it isn't. Okay, I understand. Well, we've pretty much come to the end of this second segment. We've got like a minute left in time here, so I want to thank you, all three of you, again for being here. This has been an incredibly enlightening conversation for me. Again, I'm going to let the folks know that they can send us queries, info@referencepointtv.com. We'll get them to the individuals in case you have some questions about Covered California, about the insurance activities and what that means, or about the care, how it might impact from your physician practitioner perspective. And with that, thank you all for being here. This has been really cool. I greatly appreciate it. October 1st is coming right down the pike, so it's going to impact all of us. And so, ladies and gentlemen, I hope you learned something out there. We'll see you next time on Reference Point.